Welcome to Dr. CM Edcast, your go-to resource for medical learning. Through discussions, case studies, tutorials, and debates, we help you learn, grow, serve.
Breathing. We do it thousands of times a day without even thinking about it. But underneath that simple, rhythmic act is this incredibly complex and elegant mechanical system. Today, we're going to explore the mechanics of pulmonary ventilation to really understand how our lungs do what they do. So we'll start with the basics, the building blocks, the static volumes and capacities that kind of define the space inside our lungs. Then we'll get things moving and see how timing can tell us a lot about lung health. After that, we'll dig into the physics of it all, things like compliance and surfactant. And finally, we'll figure out what the actual energy cost of taking a single breath really is.
You know, to really understand how something works, sometimes you have to look at it when it's still. So that's where we'll begin. We start with 4 basic, non-overlapping volumes. Just think of them as the fundamental puzzle pieces for measuring our lungs.
First up, and probably the one you're most familiar with, is tidal volume. This is just the air that's moving in and out with every normal, quiet breath you take. For an average adult male, we're talking about 500 milliliters, which is about half a liter.
This graph, a spirogram, shows you exactly what that looks like. See those small, regular waves? Each one of those is a single, quiet breath in and out. It's the baseline rhythm of our breathing when we're just resting.
But of course, you can breathe in a lot more deeply than that, right? Well, that extra volume of air you can pull in after a normal breath, that's called the inspiratory reserve volume. And it's a huge reserve, somewhere between 2 and 3 liters. It's what athletes tap into when they need to maximize their oxygen intake.
And it works the other way too. After you breathe out normally, you can still force more air out of your lungs. That extra amount is the expiratory reserve volume. It's about another liter of air that you can consciously push out. Singers use this all the time to hold those really long notes.
Now, this is really important. Even after you've pushed out as much air as you possibly can, your lungs are never completely empty. The air that's always left behind is called the residual volume. This is what keeps those tiny little air sacs, the alveoli, from collapsing completely. And you actually can't measure this with a simple spirometer like you can with the other volume.
So we had these 4 individual pieces: tidal, inspiratory reserve, expiratory reserve, and residual. They're the fundamentals. Now let's see how we can combine them to get a much bigger, more functional picture of our lungs through what we call capacities.
And the math here is actually pretty simple. Take your normal breath and add your deep breath reserve. That's your inspiratory capacity. The air that's left in your lungs after a normal exhale, that's your functional residual capacity. Everything you can possibly move in and out, from your deepest breath in to your hardest breath out, is your vital capacity. And finally, you add all of that to the air that never leaves, and you get your total lung capacity.
So if we go back to our spirogram, you can see how this all fits together. The smaller volumes literally stack on top of each other to build these larger capacities. This gives us a beautiful visual of the full range of our lung function, from the very top to the very bottom.
Okay, so measuring how much air the lungs can hold is one thing. But when it comes to diagnosing diseases, it's often way more important to measure how fast that air can be moved. And that brings us to dynamic lung function.
This is where we bring in a crucial measurement called FEV1. It's pretty much what it sounds like: the volume of air you can force out in the very first second of a really hard, fast exhale. And it's one of the most powerful and common tests we have for spotting airway diseases.
Now look at these 3 curves. They each tell a completely different clinical story. The normal curve is nice and steep. The air comes out fast. With an obstructive disease like asthma, you see that scooped-out shape. It shows that air is trapped and coming out really slowly. And then with a restrictive disease like fibrosis, the total amount of air is smaller, but it comes out relatively quickly. The shape of the curve tells you almost everything you need to know.
This table really just boils it down to the numbers. A healthy person can get about 80% of their air out in that first second, but in obstructive disease, that ratio just plummets because the FEV1 is so low. In restrictive disease, both numbers are lower, so the ratio can actually look normal or even high. That ratio, that's the key differentiator.
So we've measured the volumes, we've measured the speeds, but what is it about the lung itself, the physical properties of the tissue, that dictates all of this? Let's dive into the underlying physics.
You know, it really all comes down to this constant tug-of-war between 2 opposing forces. You've got elastins, which is the lung's natural tendency to want to snap back, like a stretched rubber band. And then you have compliance, which is the opposite. It's the lung's stretchiness, its ability to expand. Healthy breathing is all about having the perfect balance between these two. Now, a huge part of that elastic snapback comes from something called surface tension. Those tiny little air sacs in our lungs, the alveoli, are lined with a very thin layer of fluid, and the molecules in that fluid are always pulling on each other, constantly trying to make the air sacs smaller.
So how in the world do our lungs fight this constant collapsing force? Well, they have a secret weapon. It's a remarkable substance called pulmonary surfactant. These molecules get right in between the water molecules, breaking up that surface tension. This makes it so much easier for the alveoli to inflate and, just as importantly, to stay open.
And the benefits of this are just profound. Surfactant dramatically cuts down on the effort it takes to breathe, it stops our alveoli from collapsing, it helps keep fluid out of our lungs, and it makes sure all those little air sacs inflate nice and evenly. It's absolutely essential for normal lung function.
All right, we've gone through volumes, rates, and the physics of stretch and surface tension. Let's put this all together and ask a really practical question. What's the actual energy cost to perform this mechanical act of breathing? Well, when you're just breathing quietly, most of the work, about 65% of it, is spent just fighting against that elastic recoil we were talking about. The rest of the energy is spent overcoming friction, both from air moving through the airways and from the tissues rubbing against each other.
This pressure-volume loop is a great way to visualize the work of breathing. It might look a little complex, but the area inside that loop literally represents the amount of energy your muscles have to spend to take one single quiet breath.
So what does that cost? What does it all add up to? Well, amazingly, under normal resting conditions, all of this work only uses up about 2 to 3% of your body's total oxygen. It's an incredibly efficient system. And that brings us to our final and maybe most important question. We've seen just how efficient the system is when it's healthy. But what happens when things go wrong? When airways get blocked or lungs get stiff? How does that fundamentally change the energy we have to spend? Not just for one day, but for every single breath we take for the rest of our lives.